This video describes the basic structures and parts of pterygium, followed by surgical steps in pterygium excision in primary and double-headed pterygia, along with the use of amniotic membrane wherever necessary. The structures on the ocular surface include caruncle, semilunar fold, tenons, and the conjunctiva. Pterygium grows as an abnormal subconjunctival fibrovascular tissue, which encroaches eventually onto the cornea, most commonly on the nasal side, but may occur temporally too. Pterygium is divided into body, neck, and head. The image shows the cross-section of pterygium in sagittal plane at the level of limbus from bottom to top, containing limbus, tenons and subconjunctival fibrovascular tissue, and then the conjunctiva. The plane of dissection should be between the conjunctiva and the fibrovascular tissue of pterygium, beginning from one border of the neck to the other border. Then, adequate separation of the fibrovascular tissue from the overlying conjunctiva and the underlying sclera should be done, extending the plane towards the entire pterygium body. This tissue is then excised at its root, separating from the healthy tenons. The head of the pterygium is excised by using shearing force or cut and peel technique. The residual fibrous tissue is scraped off from corneal surface and limbus. Removing the residue at the limbus is a very important step to prevent the recurrences. The corneal surface is smoothened using a diamond burr. Adequate hemostasis should be achieved. Sealing the gap, that is, the space between the conjunctiva and healthy tenon should be closed by opposing their free edges. This is another important step to prevent the recurrences. A conjunctival autograft is harvested and secured on the bare sclera with fibrin glue or sutures. The donor area is then closed. In double-headed pterygia, the steps of pterygium excision are similar, but the closure of bare sclera depends on extent of bare sclera exposed and the size of conjunctival autograft required. Here, three various scenarios are discussed. In scenario 1, excision of large nasal and large temporal pterygia results in large bare scleral area on either side. Amniotic membrane graft is used to cover the bare sclera, trimmed according to the requirement, and then tucked under the conjunctival edges. The conjunctival autograft is harvested, split into two horizontally, and secured above the amniotic membrane graft, covering the limbal extent. In scenario 2, excision of small nasal and small temporal pterygia results in smaller bare scleral area on either side. The conjunctival autograft is harvested and secured on the nasal side, while temporally only amniotic membrane graft can be placed. The other option is the harvested conjunctival autograft is split into two horizontally, and each half is secured on the bare sclera without the need of amniotic membrane graft. In scenario 3, excision of large nasal and small temporal pterygia results in large bare scleral area on one side and smaller area on the other side. The larger site is covered first with amniotic membrane and conjunctival autograft is placed above it, while the smaller site only amniotic membrane is sufficient. The other option is amniotic membrane graft is placed on larger side alone, and then the harvested conjunctival autograft is split into two horizontally and each half is secured on either side. The following is the summary of various scenarios just illustrated. The surgical pearls in pterygium surgery are: number 1, sealing the gap; 2, meticulous removal of abnormal tissue at the limbus; and 3, use of amniotic membrane as bandage to cover the bare area.